This is going to be our little introduction to pain modulation. So we're going to discuss it briefly, pain theory and management of pain in the light of modalities and how can we use modalities to manage pain. And we'll talk about this as we talk about each different modality. We will go into much more depth on this in clinical neurology next quarter. We'll talk about all the different levels of pain management in our nervous system and how it goes on, but we're just going to touch on it. This is going to be an introduction. So like I said before, I've probably said it before and I'll say it again, a lot of things come up frequently in the whole course of study, and when it comes up more than one time, you know that it's pretty important. So pain is the most common symptom prompting patients to seek medical attention and rehabilitation. So a lot of times people wouldn't come into PT if it wasn't for pain. They go to their doctor and they say, you know, my neck really hurts and I thought it would go away, but it's not going away. And the doctor writes them a referral for PT. So a lot of times that is their entry into the world of physical therapy, the fact that they're having pain. If they weren't having pain, they probably wouldn't have come in. So pain serves a useful biological function. It tells us, oh, get your hand out of the fire. You know, that's good. Or it's a warning of actual or potential tissue damage. So you don't have to have tissue damage in order to have pain. It could just mean that, oh, there's the potential for tissue damage, so you have to take some action. It's the alarm system of our body, and it's an essential function for survival. It's also not simple. It's a complex, it's not just a mechanical, step on a tack, it hurts, you step off the tack. It's a complex interaction between mechanical, neurological, psychological, and sociological factors. So there are lots of things that contribute to the pain experience. One of the programs that we have in the clinic where I work is a chronic pain education program. Chronic pain is and we'll talk a lot more about this in neurology next quarter, but it's a very complex issue. There's not an easy fix for it, but education is a huge contributor to getting better from chronic pain. If you know what's going on in your body, you have a much better chance of dealing with it. So acute pain is a direct result of actual or potential tissue injury due to a wound, disease, or invasive procedure. It's expected to resolve within 3 to 6 months depending on the pathology. So when we were talking about the acute and subacute and chronic phases of inflammation, well, acute pain is lasting longer. You see that 3 to 6 months. Then acute inflammation only lasts for a few days to a week. Acute pain can last longer. But something happened, or there's the potential for tissue injury because of a wound, disease, or invasive procedure. So depending on what's going on and what's causing the pain, acute pain should resolve within 3 to 6 months. So chronic pain, the material, the book says it's very common in the United States. So it's interesting. What is causing us to have this chronic pain? So the criteria for classifying pain as chronic is it's enduring or recurrent. So you always have the pain, or it just happens all the time. It recurs all the time. It persists longer than typical for a condition. So like say I got a paper cut. That's a condition. Usually it stings like the dickens when you first get it. When you first get the paper cut, it sort of throbs and aches. Maybe it hurts a little the next day, and then maybe 2 days later you don't even have it anymore, or it's already healed. So chronic, it's very uncommon that a paper cut will result in chronic pain, but let's just say for this example that it does. You say, well, it stung and then it throbbed and now my whole arm is throbbing. So it's longer than typical or it's associated, or sometimes it's associated with an intermittent or chronic disease. So if you have some other chronic disease process going on, you might have chronic pain associated with it. Sometimes if either your body has an inadequate response to appropriate care or invasive care. In other words, your immune system and your inflammatory process just aren't up to the task, and so you end up with chronic pain. But a lot of times chronic pain can result in a significant impairment of functional status. So referred pain, it's pain felt at a location distanced from its source. It's usually not closely localized. It's diffuse and variable in distribution and character. So it could be like, my back kind of hurts. Sometimes different organs will refer pain to different areas. There are some charts in the book, and we'll talk way more about this in neuro. But say you're having, you have gallstones, you're having gallbladder pain, it can actually refer to your low back. So referred pain, there's a source of pain, but you feel it at a different location. Radicular pain is also pain felt at a location distant from its source, but it's generally located in a specific neural distribution, and generally associated with other deficits such as sensory or motor losses. So people that have sciatica, it's pain that goes in the sciatic nerve distribution. I know you talked about dermatomes and some peripheral nerve distributions a little bit in tests and measures this summer. And so the difference between radicular and referred pain, radicular, there is a specific neural distribution associated, and referred pain, it's just in another location besides the source of the pain. So acute pain is usually what we're going to refer to as biologically meaningful, meaning it's time limited, it's just a short period of time. There's some increased muscle tone, increased heart rate, increased blood pressure, increased skin conductance. The intensity and the location of pain is related to the degree of tissue inflammation and damage. So lots of tissue inflammation, lots of pain. Little bit of pain. It's usually well localized and well defined. You can say it hurts right here, and it serves a specific function, either to protect the area or to localize the source of the pain. So chronic pain often starts as acute pain. It continues beyond the initial stimulus. It's usually greater than 3 to 6 months, and it continues beyond tissue damage or threat of tissue damage. And a lot of times it can be associated with physical, psychological, or social dysfunction. There might be some sort of secondary gain associated with being in pain. A lot of times chronic pain is not as well defined in terms of location. It can be a more diffuse, throbbing, overall type of pain. And referred pain is often diffuse and variable in distribution and character, and radicular pain has that specific neural distribution. So we're going to talk a little bit about the mechanisms of pain reception and transmission, and we're going to go into much more detail of this in neuro, but we have some certain fibers, nerve fibers that respond to certain amounts of pain, certain types of pain. The first one that we're going to talk about is peripheral sensory pathways that are A delta fibers. They're small myelinated fibers. They respond to intense mechanical stimulation and heat or cold. So these are sensations that are sharp, stabbing, pricking pain, and they're not usually blocked by opioid medications. So when in tests and measures, when we were doing the neurological testing or the sensory testing, when we did, is this sharp or dull, sharp or dull, the sharp sensation is carried on the A delta fibers. They're small fibers and they carry that sharp sensation. And they also carry heat and cold sensations. C fibers are smaller. They're usually free nerve endings, So a lot of times those A delta fibers, they're involved in specific tissue sensors. The C fibers are small and unmyelinated. They're the sensations that are dull, throbbing, aching, burning, tingling, or tapping. Lots of words to describe pain. With the A delta fibers, it's a quick onset and not very long lasting. With the C fibers, it's a slow onset and longer lasting. It's usually, instead of being specifically localized, it's diffusely localized and can be accompanied by sweating, increased heart rate, blood pressure, or nausea. These guys are blocked with opioid medication. So kind of interesting. Some fibers respond to it, some don't. So what that tells me, as a neuro geek, is that the C fibers have receptors for those opioids, whereas the A delta fibers don't have receptors for the opioids. That makes sense, right? Well, hopefully it'll make sense next quarter when we're talking about neuro. So also in our peripheral pathways, we have these other fibers that are called A beta fibers. The A beta fibers we like because they're non-painful sensations, vibration, stretching, mechanical pressure. Sometimes the A betas are involved in abnormal prolonged pain perception, but the pain quality that we perceive depends not only on the type of nerve, but on the type of tissue being stimulated. So things feel different on different tissues, and that makes sense. And as we start to explore it more, hopefully it'll make more sense to you. So this is a little diagram of the spinal cord cross section, just as one level of the spinal cord, and some of the nerve fibers that are entering into the dorsal horn of the spinal cord. So the dorsal horn of the spinal cord is where the sensory nerves synapse with the second order neurons that are then going to take the information up to the brain. So we've got A delta fibers coming in there. We've got C fibers. We've also got A betas, even though they're not in this diagram. The cell bodies of those sensory neurons are in the dorsal root ganglion. They synapse with the second order neurons in the dorsal horn of the spinal cord, and then they go up the spinal cord to the brain. Okay, so here's a nice little picture of what we're going to start talking about, is called gate control. It's also called the counter-irritant theory. So the basic idea is that you get a summation of excitatory and inhibitory influences in the dorsal horn of the spinal cord that determines if the pain signal is actually going to go up to your brain in order for us to perceive it, or whether it's going to just stop at the spinal cord. So, and it's influenced by lots of things: attention, emotions, past experiences. When we're talking with patients in the clinic, a lot of times we ask them to rate their pain on a scale of 0 to 10, 0 being no pain and 10 being the worst pain you can imagine, or emergency room pain. Well, a lot of people have a pretty hard time determining what is what's 10 out of 10 pain. And I've had people sit, and I probably will always, every place you work in therapy, you'll see this. Someone is sitting there, they appear to be very calm, they're not twitching, they're not crying, they're not scrunching up their shoulders, they have very relaxed body posture, and you ask them their pain level and they say, 9 out of 10. And so nobody's invented a painometer. We can't slap it on them and say, oh, well, you're at 7 out of 10, whatever. So sometimes having some of those pain scales that relate a little more to function can help. There are some objective pain scales that you can use. There's one that's called the FLAC scale. It's face, legs, arms, crying, and consolability, FLACC. So face, is their face relaxed or is it scrunched up? Their legs, are they twitching their legs? Are they holding them still? Same with the arms. Crying, are they crying? Are they not crying? Consolability, can you distract them and talk them out of their pain? And that relates to a number scale as well. So they're different pain scales. So in the gate theory, we get these A delta and C fibers, nociceptive, meaning pain transmitting fibers, transmitting that pain up to the dorsal horn of the spinal cord, and from there going on another neuron to the thalamus, where that's where we can perceive the pain. It comes to our attention. The A beta fibers, which are non-nociceptive fibers, those can be stimulated by things like soft tissue mobilization, electrical stim, vibration or mechanical forces. Ultrasound is another one. They actually go up and they stimulate an inhibitory neuron that helps block those C fiber and A delta fiber nociceptive messages. So that's our gate theory, or our counter irritant theory. So we have one irritant that is stimulating the nociceptive fibers. We have a counter irritant like massage, like ultrasound, like ice, that is inhibiting those same fibers to keep the pain information from getting up to the brain. And that's how a lot of our physical modalities work to control pain. So there's a little video in the module that is a really kind of simple explanation of gate theory that I really like. It's kind of goofy. It's got these little animated characters explaining gate theory, but it's a very good place to start, I think. So the gate control theory, the pain severity is determined by the balance of excitatory and inhibitory inputs into the spinal cord. So if you get more inhibitory inputs, which are those A betas, you can actually keep the pain from going from the spinal cord up to the brain. There is another, and that is considered an ascending pain control system. So you're going from the periphery to the central nervous system. You're stopping it at the periphery. It's not getting to the central nervous system. There's also some descending systems, and we're going to talk way more about the different levels of anti-nociception in neuro, but we're just going to talk about these two in this class because these are the two that we can affect with modalities. So the endogenous opioid system, that's our endorphins, are brain chemicals that are specifically created to control pain by binding to specific opioid receptors. And remember how I said, oh, well, these nerve fibers probably have opioid receptors and these other ones don't? So that's where our endogenous opioid system can help control pain, and that's a descending system, meaning the endogenous opiates are natural painkillers that are created in our areas in the brainstem that release these substances. They send input from the brainstem down to the dorsal horn to inhibit pain. The ascending system in gate control, or the counter-irritant theory, affects the dorsal horn from the periphery. The endogenous opiate system affects the dorsal horn from the brainstem. So these natural painkillers can be triggered by non-painful stimuli as well as by intense pain, intense exercise, laughter, meditation, and stress. So a lot of times you can get these natural painkillers going. There are lots of different names for the different endogenous opioids, opiopeptins, endorphins, and enkephalins. Serotonin is a neurotransmitter. It can also be an endogenous opiate. And so that is our brain's way of controlling things from the top down. And then we have the pain modulation from the bottom up with the counter-irritant system. So this is another little diagram of the same thing. I'm not going to go through this in detail, but sometimes it helps to have the little diagrams and go, oh yeah, I get it. The A delta and the C fibers are sending a pain signal. The A beta fibers are going in there to block it, and whether or not something gets to your brain depends on how those guys interact in the spinal cord. So the conditions that open the gate, meaning if the gate is open, you can feel pain. or you're going to, perceive it in your brain. The extent of the injury or inappropriate activity level, like you're doing more than those tissues can handle right then. So it's a physical condition. Emotional conditions like anxiety, worry, tension, or depression can open the gate. And mental conditions like being bored, I think that's funny. Being bored can cause you more pain. But anyway, being bored or focusing on the pain, like I'm sure we've all met that person who can't talk about anything but their pain. And that can actually open the gate and make their pain worse. Conditions that close the gate can be physical conditions like medications or counter-stimulation, heat, massage, different modalities that we're going to do. Emotional conditions like positive emotions, relaxation, rest. Those are nice, right? And mental conditions like intense concentration or distraction, or involvement and interest in life activities. So it's pretty hard to feel miserable when you're petting a puppy, right? That's the idea of the mental and emotional conditions. You can have these positive emotions, listening to nice music, relaxing, resting. Those can close the gate. They can make pain sensations less intense. So I talked about the pain scales, and I'm sure Jamie talked about them this summer. So a lot of times you'll have a visual analog scale where you have the smiley faces or the frowny faces, and the person picks the one. There are the numeric scales, the 1 to 10. Sometimes it's comparison with a predefined stimulus, like a lot of women who've had children will relate to childbirth as being 10 out of 10 pain. Those of us who haven't had children really can't use that one. But you can say it's like getting your thumb caught in the door, comparison with a predefined stimulus. There are semantic differential scales using word lists or categories to describe the pain. So one of the ones that I like to use in the clinic, if somebody's having trouble assigning a number, I have a pain scale which I'll share with you. I'll post it in the module. And it says 1 out of 10 pain is, the pain filters into your perception every now and then. 2 out of 10, maybe it's several times a day. 3 out of 10, it's there all the time, but it doesn't keep you from doing anything. 4 out of 10, 5 out of 10, it starts to affect your activities. 6 out of 10, you can only do things if you're really concentrating. So you get the idea. It gives you more description of each category, so it helps you determine which level you are. There are also other measures. Sometimes we'll have people, when they're in the chronic pain education program, we'll have them do pain logs where they can begin to equate which activities increase their pain and which ones don't. There are body diagrams where people color in the areas of their pain. Sometimes that can be a little bit of a loaded question because you'll see people that color in the whole body. Sometimes a structured interview. A lot of times when the PT is doing the initial evaluation, they can ask questions that are leading people into what type of pain they're having, like the quality of their pain, the location of their pain, what makes it better, what makes it worse, that kind of thing. And then, of course, physical examination and testing. The physical agents that we're going to do in this class, a lot of times they benefit pain management by directly modifying or moderating inflammation, modulating pain at the spinal cord, stimulating those A beta fibers, altering nerve conduction. So heat and ice are two of the ones that alter nerve conduction. So with ice, you slow down nerve conduction, so you can actually decrease your pain by slowing down nerve conduction. Ice also affects inflammation and swelling, and that can alter it moderates that inflammation, altering your pain. There are some physical agents, there's some E-stim applications that increase endorphins, and so you can start to stimulate that top-down pain management. The physical agents may also help to resolve the underlying cause. So ultrasound, for one example, can increase vascularization. It can increase the microhealing at the tissue level. It can help accelerate healing, so it's helping to resolve that underlying cause. Ice and elevation can help with the swelling and the underlying cause of the pain might be swelling on pressure on the nerve tissues, and so that can help resolve it. The other thing that is beneficial about physical agents is it allows the patient to interact with their injured body parts and practice their own pain management skills. A lot of times people are so freaked out by their injury they don't want to touch it. Oh my gosh, it's hypersensitive. So if you do something, a modality that feels good, they start to have a more positive interaction with their injured body part, and that can really help with their healing. So it also, there aren't the same kind of side effects that there are with medications with physical agents, and so by using a physical agent to manage your pain rather than a medication, you can also avoid those medication related side effects. So opioid medications in particular, they depress your digestive system, they depress your respiratory system, they can cause constipation by depressing your digestive system, they can make you sleepy, they can make you emotional and crabby, or emotional and teary. Well, if you do ice, it doesn't do any of those things, and a lot of the other modalities that we use. So a lot of times the physical agents give us a chance to avoid those, or maybe even decrease the medication enough so you're not getting the side effects. So the commonly used types of physical agents in therapy, of course, are cryotherapy, cold therapies, thermotherapy, heat therapies, electrical stimulation, and traction. So all of the ones that we talk about in this quarter are pretty much fall into one of those categories. Some of them fall into more than one of those categories. So we'll talk about each one when we get to it. So of course, people are going to be on medications frequently. It's good to know the effects of medications, so we can talk with our patients regarding that. Of course, it's out of the scope of our practice to prescribe or recommend dosages for medications, but if we know what we're talking about, we know when to refer them back to their doctor. So the type of pharmacological approaches that are used for pain management are systemic analgesics like NSAIDs, non-steroidal anti-inflammatory drugs, acetaminophen, which is Tylenol, opioids, anticonvulsants, which can be, sometimes people call them muscle relaxants, and antidepressants can sometimes have an effect on pain as well. Spinal analgesia, where they actually inject the analgesic agent into the spinal cord. A lot of times that happens when they're doing surgery. Instead of doing a general anesthetic, they do what they call a spinal block, where they block at a certain level, and it's better because it's not as damaging to your system. Local injection, where you like get a cortisone injection in your knee, or topical analgesics, things that you apply to your skin. So the common side effects of opiates, I just mentioned a little bit about that: nausea, vomiting, sedation, gastrointestinal slowing, and respiratory suppression. So, so many people can't tolerate opioids because of one or more of those side effects. There are dangerous side effects, respiratory suppression being one of them, where if you're over-medicated, you can actually stop breathing. And then tolerance, dependence, and addiction. There's a lot of focus on that in healthcare these days, and there are a lot of different factors that contribute to it. The ones that we often see in physical therapy are, of course, the nausea and vomiting, very unpleasant. You don't want to be doing exercise when you're feeling nauseated. Sedation, like a lot of times when I get people just immediately post-surgically, the first few visits, they're pretty out of it because of the sedation effects from the opioids. And the gastrointestinal slowing, people have digestive issues, and constipation is a big side effect from opioids. And then the respiratory suppression, they're not breathing as well, and we know we need oxygen for healing, and we need to breathe to get oxygen. So there's some pretty serious side effects from opioids.